Good afternoon. Thank you all for being with us. I hope that you've enjoyed the day. It's been a great day to be together, and we have a great conversation coming up. My name is Josh Trent. I'm the CEO at Leavitt Partners. We're all policy government affairs solely run in Washington, D.C., where it's federal healthcare policy, the intersection of the federal government and the health sector. And we had the privilege to really just start a great conversation with our final speaker for the day. We have the privilege to hear from Meena Seshamani, who is the Secretary of the Maryland Department of Health. I'll just give a brief introduction for her background, and then I'll invite her to join me on stage. So the Secretary has a big job. She leads the Department of Health in the state of Maryland here. Approximately 9,000 employees working on public health and Medicaid and disability and behavioral health in 11 state-run facilities, budget of upwards of $20 billion. Meena is no stranger to health policy. She previously worked as the director of Medicare, the Center for Medicare at CMS. And was very impactful there, working on the Medicare drug prescription negotiation program, among other priorities, value-based payments and physician fee schedule issues. She also served as Vice President for Clinical Care Transformation at MedStar Health, being known to many of you here in the area. She conceptualized, designed, and implemented population health tools and programs, initiatives there. And was a senior leader of the membership of that system that has more than 10 hospitals and more than 300 outpatient sites. She's also a double doctor, so she's a Hopkins-trained MD, which is impressive, but she also is an Oxford-trained PhD economist and was a Marshall Scholar. So super smart, super accomplished, and a super asset for the state of Maryland. Will you join me in welcoming the Secretary? Thank you for being here.
Absolutely.
It's been a great day with a lot of different organizations thinking about the future of health, both in the state of Maryland and here at our nation's doorstep, and all the change that's happening at the federal level. I want to start with a question. We'll have time for some Q&A from the audience members if you think about your questions, but I'll get started with a few. So you took office April of last year. What a time of federal policy change and transition has been, and how much we've seen more since then, particularly with the changes that's coming from OB3A and the kind of rapid cycle of rules and regulations and guidance and implementation and systems change. What have been some of the biggest challenges that you've seen, maybe from that and maybe just from other things in your role? And then how are you thinking about what some of the biggest opportunities are?
Well, thank you again for having me, and it's great to be here with everyone. You know, I would say that we could talk about individual challenges that we have, implementing a whole new law in a very tight time frame, navigating changes that have occurred with funding streams, with changes in federal funding, with changing vaccine guidelines. I think at the end of the day, the common foundation with all of those is the sense of uncertainty and anxiety that has been created in the ecosystem for healthcare organizations, for businesses, since majority of people's health comes through employer-based insurance, and most importantly, for the people of Maryland, where I think a lot of people are like, what is going on? And what does this mean for me? And how do I keep my family healthy? And I think that also is a challenge, and it's also then an opportunity where you have to think that you can't do things the way they have always been. And what do they say? Necessity is the mother of invention, right? And so where we are able to, for example, with vaccines, be able to really engage with people to provide information that can help them as they are making decisions with their doctor how to stay healthy. We issued standing prescription orders so that people could continue to have access to the COVID vaccine, to the hepatitis B vaccine. We followed information from the American Academy of Pediatrics and American College of Obstetrics and Gynecology. And now we have passed the VAX Act such that those recommendations that are based on leading medical organizations, those recommended vaccines will continue to be covered at no cost by health insurance plans regulated in Maryland. So just, again, trying to provide those avenues of predictability and consistency for the decisions that people are making and reducing barriers to access. I think for HR1 or OB3A that you mentioned, with the additional requirements on eligibility and enrollment, being able to leverage technology to really streamline eligibility and enrollment to make it easier for people to navigate, because we know that in states that have implemented these increased requirements, there are people who fall off the rolls because they're eligible, but they just can't make it through the process, which is ultimately an issue that all of us have been a patient in healthcare. Healthcare is not easy to navigate, even for those of us, myself included, who are supposed healthcare experts. You have moments where you say, oh my gosh, I don't know where to go for this or what this form is saying. And so really capturing the opportunity to look at how we engage with people differently here, to both automate things as much as we can, and then engaging with our community partners to be able to get the word out, not in a one-time 8-page wonky policy document, but repeated engagements over time, leveraging the health plans, local community organizations, clinicians to say, okay, there are changes coming. Here's what you need to do right now. Stay tuned for more information so that people really feel that someone is holding their hand. So I think those are just some examples of where, in navigating the uncertainty and anxiety that is out there, I think there are ways that we can find different ways to partner together to improve the way that we're delivering care to people.
I want to ask you about partnering. You've had some great wins in interterritorial. So you mentioned the VAX Act, but also when you look at the HET model, Maryland's commitment there, or rural health transformation funds, you've been busy, you've accomplished a lot. What are 3-4 things that you're really excited about that are both maybe in the rearview mirror or right on the horizon?
Well, maybe I'll start with where you left off on the rural health transformation program. We had 6 weeks to submit an application. It was ready, set, go, and Maryland got twice the national average per capita amount on the application, and I think that very much was because of the partnership, coming back to what we were talking about, the partnership with everyone on the ground. I mean, we went to our local health departments and said, okay, get your communities together because we need to get ideas from people. And I think the proof was in the pudding that really what we put forward in our application had the voice of the rural community. So we are focused in 3 areas. The first is workforce. We all know that there is a shortage in healthcare workforce, and particularly in rural areas. And we are basically investing in shovel-ready projects that can just be ramped up. So for example, investing in training for peer recovery coaches. For people who have substance use disorder, are in recovery, it is a great way to provide some job training, which then enables them to share. You leverage their lived experience to help others, and also reduces risk of relapse because you're providing economic security and a life moving forward. Our second bucket is around innovation and how do we bring care through mobile health, telehealth. I know that's an area that I know you all have been talking about at this conference. And the third area is around food. And here too, not only where are we providing healthy food to people and offering outreach on what is healthy eating, but also bringing it back to the source and investing in our local agriculture. So part of what we're doing with the Rural Health Transformation Program is investing in cold storage and food aggregators and hubs for distribution so that when we are doing things like medically tailored meals and produce prescriptions, that food is actually coming from our own farms, which then boosts the local economy. And when you think about that full circle, when I was out in Western Maryland in Appalachia doing a rural healthcare roundtable, one of the things that they commented on with workforce is it's great, you can get people to come on a lower payment program and they stay for a few years and then they leave. What is a reason for that? Because of what's happening in the underlying economy in those areas. So by investing in the local agriculture through our Rural Health Transformation Program, you're also creating that win-win where you are fundamentally changing the way that communities are, which then is a virtuous cycle for all of the other things that they want to, work together to improve for those communities.
It's really tremendous. Someone who's been to Western Maryland a lot and seen some of those farms, it's really exciting to think about what that potential is as that gets rolled out in the next few years. I know one thing that is near and dear to a lot of folks' part here, we see a lot of interest at the federal level and the state level, is justice-involved populations. Individuals who not only experience the justice system, but also have gaps in care, often have ongoing behavioral substance use, issues in their life that the healthcare system interacts with and needs to take care of. I know that's something that you've been very forward-leaning on for the state of Maryland. Tell us a little bit about what kind of work is underway there.
Yeah, I guess I really like the complex areas where when you have multiple systems that are hard to navigate, then people can fall through the cracks, right? And I think that justice-involved people with behavioral health needs is a prime example of that. So first, on just an organizational end, we have 11 state-run hospitals. I used to be, as you mentioned, I used to be in the system leadership for MedStar Health. And I think there really is a benefit to having a systematized approach to how you do things, because you can share best practices, you can work together on policies. And so I brought in Dr. Anita Everett, who is a psychiatrist, to lead all of the hospitals as a health system. I also brought in Sonia Chesson, who's a senior advisor, so that she really could focus on that continuum of care for people who are justice involved. So thinking about the, from before there is an interaction with the justice system, when someone is in crisis, is there something that can help them aside from ending up in the justice system? So we have been investing in 988. We had a 25% increase in our use of the 988 hotline. We have crisis teams in 19 jurisdictions to be able to go out to where people are when they're in crisis and be able to support them with what they need rather than having them become part of the justice system. Moving from that front end to if someone is involved in the justice system and then ends up getting hospitalized in one of our forensic hospitals. From the moment that they are admitted, we are starting to work on their discharge planning, because we want to make sure that we can have things ready so that as they get better, then they're able to move along and get back to the community. And then that will open up space for other people who are coming in. We are also working on our discharge planning to make sure that, for example, we have residential treatment facilities. And so we're doing a lot of work in our local communities looking at those residential rehabilitation programs and seeing where there are opportunities to make them more robust. So as you can see, we're really looking across that entire continuum, because we know that there are people who need beds, and we also know that being in the hospital is not necessarily where everyone needs to be.
Awesome. You can't enter a conversation today without bumping into the issue of AI. So, and obviously it holds a lot of promise in healthcare. There's also particular challenges as you think about managing risk and patient consent and awareness and privacy, all of those issues that a lot of us are spending our time thinking about and working through. How can we think about, from the department's perspective, like how are you all thinking about the best use cases for AI? Where are you seeing ROI, and kind of what's on the horizon for you?
So I think there are two aspects to AI for a regulator. The first is how we are providing guidance and guardrails around AI for those that we regulate, right? Because we have to have privacy and security and safety in place for our partners who are using AI. We are reviewing all of our AI guidelines again because the field is rapidly changing, and we want to be able to stay up on that to make sure that the AI tools are HIPAA compliant, et cetera, et cetera. I think that there's also the AI that we use as a department. That spans from what do our own hospitals use, because we have 11 state-run hospitals. Thinking about how our Medicaid program can leverage AI. For example, we have deployed AI to support eligibility and enrollment. Coming back to what we were talking about with OB3A, where we can use technology to improve efficiencies, reduce friction points so that people can get through the process and get the care they need. And I think there are also opportunities to think about AI in the public health space in terms of disease surveillance, in terms of oversight of providers. So both from the lens of regulating AI and from the lens of leveraging AI, this is something that is a priority for us.
I want to pivot to your time at CMS. You had a great reputation for being very accessible, very thoughtful in your time at CMS, working in the Medicare program. A really important time. Advancement of value-based care, Medicare drug price negotiation program, the kind of COVID era, and all of the Medicare flexibilities were critical to the healthcare ecosystem in being able to work through that very challenging time. Now you're on the state side, and I think a lot of kind of lay level folks may not think always about the degree to which healthcare, even at state level, is impacted by Medicare. Obviously, you have a dual population that intersects. But how did you think about the work you're doing now differently, or that in a way that would be distinct from if you'd not had that experience?
Well, I think Maryland is in particular unique because of our payment model. You had mentioned the AHEAD model. Maryland is the first state in the country to negotiate this new AHEAD model with the current federal administration, whereby we have alignment across all payers, including Medicare. And I think that's really important because having worked as a clinician and having led, in a health system, if you don't have alignment of all of the payers, number one, it's very confusing to navigate when all you want to do is take the best care of your patient that you can. Number two, it can create an issue where when you squeeze one end of the balloon, the other end pops open, or right hand doesn't know what the left hand is doing. You can use whatever analogy, but that lack of coordination stymies the kind of real impact that I think those of us in healthcare want to have. So the new AHEAD model builds off of our old payment model, our prior version of the all-payer model, which saved $1.6 billion in Medicare spending. And importantly, because it is an all-payer system, it means that that is savings in overall system. Because it's not that, okay, money was taken out of Medicare and instead led to higher premiums in the commercial market, right? And so I think that's where it's so important that we continue to work very closely with the federal government on both Medicare and Medicaid, because they are an essential part of the ecosystem of healthcare in our state. And they interact very much with what happens in other markets, in the commercial market, with our marketplace, with the uninsured population, where with changes that are happening with the ACA subsidies, with the HR1 year, evaluating what that means. We want to make sure that we keep as many people covered as are eligible, knowing that we have to figure out how we address healthcare needs in the smartest way possible. So I do think for all states it is very important to have that connection with the federal government, and particularly for Maryland because of how we have that alignment across payers. It really enables us to move the needle on some pretty innovative changes that can really drive improvements in care in a very smart way.
One of the things that is a commonality between yourself and a lot of attendees here is functioning from a place of leadership, having some agency and authority over, you obviously have a giant responsibility when you wake up every morning, but so many people here are operating a P&L or a division or a team. How do you think about, as a leader, with so much coming at you, kind of where do you place your bets? What do you spend your time on? And then a second part of that is, particularly a challenge for the department, you have very distinct missions, statutory missions, policy, legal obligations. How do we think about building a strategy as inclusive of those, but also responsible to those individual charges?
I mean, that summarizes the quandary for leaders, right? And I think it's a really important one because especially in complex times, it can be very easy to lose your own grounding in your foundation. And so when I started, now a little bit more than a year ago, it was honestly really important for me to just listen and talk to everyone and figure out what drove people to get up every morning, from the people who worked at the department to the people that we interacted with. And with that, we then had a leadership retreat and came up with our mission for the department to protect and advance the health and well-being of all Marylanders through systems that work for people. And from there, that has enabled us to develop strategic plans and to prioritize our work. Exactly to your point, where each of our administrations, be it Medicaid, behavioral health, disability, public health, or operations, there are things that they are each working on, but understanding how it comes up to that whole. And where there are things that very much intersect across all of these. The other thing that I would say is the engagement with the community has been so important. So we want to have a world-class health system for all Marylanders. So what are the things that we hear from Marylanders about what matters to them? And it's things like improving maternal-child health, improving rural health, reducing health disparities, making the healthcare dollar work for you. That's where the AHEAD model comes in. So I think that really has enabled us to have like the, to the point, what are your big rocks, right? And what are the things that you really want to put your shoulder to the wheel? And that's especially important to have that grounding in a time where there is quite a bit of swirl. And there's lots of things that could take your attention from here to there to this other thing. And where we do have to prioritize in times where you have budget constraints, in times where there are changes in funding that are happening at the federal level, for us to be able to say, okay, what are our joint priorities for the work we're doing with Marylanders that we have to make sure that we are keeping our eye on, and with everything going on, how does that come back to driving where we want to go? And that comes back to your first question about how the challenge then becomes the opportunity.
I love that. One advantage you have is, unlike most of us, you actually deliver healthcare. You're a physician. And so it's a really interesting skill set to bring the economic view and the clinical view together. And I think about
I can argue with myself.
There's place when you're talking to yourself, which roll back, right? We are good stuff. What do you think that kind of gives you as a leader? I mean, it seems to me like you just having worked with a number of leaders over the year, that clinical view, it is a distinct benefit and advantage. But how have you seen that play out in your work?
It is such a part of my identity to start with. I really miss taking care of patients. Actually, when I got appointed to go back into the administration to run Medicare, I had one woman give me a hug at the end of her appointment. She said, I'm gonna call the president and tell him you can't go. But I do think seeing how care plays out on the ground, it's so valuable because life doesn't work like spreadsheets, right? And so like being able to take those experiences that I've had with my patients where I have personally felt the gaps in the healthcare system and then try to address them. So one example is, the patients who I took care of who had wound care issues, where when I was a resident at 5 a.m., I'm rounding on patients that have these enormous wounds, we're packing here, there, everywhere. Okay, medically they're ready to go home. Okay, time to leave the hospital. Who's taking care of them at home? And I know like the backbone that family caregivers are to our entire healthcare system. So one of the things that we did in the Medicare program is create payments to clinicians to provide training to family caregivers, because then the person won't have their wound get infected and they end up back in the hospital. Or the number of times that I had a patient's, stomach tube fall out at home and they had to come back in and I had to like stick the tube back in. Like those are things that are all avoidable and that really make life hard for people. So that's just one example. And then it also goes in the reverse so I worked on the Affordable Care Act in the Obama administration. And I went back and I was in my residency training. And there was a woman who came into our emergency room with such bad sinus polyp disease that one of her eyeballs was protruding, like she was seeing double. And it was a 7-hour surgery to try to help her because these polyps had like eroded like her skull base. And I'm in the OR, watching my attending operate, and the fellow says to me, yeah, she finally came in because the new healthcare law enabled her to get onto her mom's health insurance because she was like a young adult. So she didn't have any insurance, but then because she was able to get on her mom's health insurance, she came into the ER to get this taken care of. And I was thinking, oh, I worked on that. And so you really then can see the value of what you do at that system-wide level and how it can impact an individual person. So I think it is really gone in both directions. And I honestly feel very blessed that I have been able to experience that full circle.
What a rewarding experience that must be. What a rewarding experience that must be. We're going to have some time for questions in just a minute, so be thinking about what questions you want. And we have some mics in the audience. If you want to probably just raise your hands, I think we have a mic runner that can get that to you. I do want to ask you, coming back to OB3 and worry impressiveness of looking at your own final rule, if I'm assuming CLS that complies with statute for pre-engagement requirements, and we have seen versions of this in fits and starts. We've never seen anything like this across the history of the Medicaid program. And there's a lot of questions about how it will get done. Obviously, there's a legislation, there'll be regulation, there'll be state action, guidance, I assume litigation, just given the nature of the policy. How do you think about your point on kind of tech and opportunity? How are you thinking about where the state's positioned, and just in a way that you have a broad swath that community stakeholders here? Do you have any messages or things that are top of mind that would be good to seep on today?
Absolutely. So first I will say that as you can imagine, all of the state Medicaid directors are, collaborating on this. All of the state HHS secretaries are collaborating. We are sharing notes. Maryland is very strongly positioned because of the one application platform that we have, Maryland Benefits, where there's a one door in where people can not only get their Medicaid eligibility assessed, but also other programs. So we are absolutely leveraging that to be able to automate what we can. That being said, it is a challenge. It is a lot of change that's happening. I mean, we're gonna leverage CRISP, which as you know, is one of the best health information exchanges in the country. We're gonna leverage CRISP to be able to collate people's diagnostic information to see, do they qualify for medical frailty exemption? We're going to be pulling in the National Student Data Clearinghouse to see, is someone a student? Because that could be an exemption for work requirements. Pulling in wage data, trying to automate as much as we can. That being said, we're all human beings, right? And as soon as the law passed, I'm sure all of you have had experience with someone who thought that their healthcare coverage was ending that day, right? I mean, it's just the nature of reading things in the news and hearing things and rumor mills. And so I think it's going to be really important for all of us to be working very closely together on getting the word out about what are the changes that are actually happening and what people need to do to be able to navigate them. And I say that also because not everybody wants to hear from me. I mean, my teenagers certainly don't, but also, like, people want to hear from people in their local communities who can help them to best navigate. And so it's really going to be important for all of us to work together to make sure that everyone who is eligible for Medicaid can stay enrolled.
All right, I'm going to turn to the audience here. I can ask questions all afternoon, but I want to make some space for you in the audience that has a question. I see a gentleman back here, and when you ask a question, if you can kind of do name and organization just to understand perspective. Thank you.
Thank you. Mike, I was like that practitioner. My question is, it's a great conference day. Majority I heard are from the others to the intervention. So my question is the secretary is, there's on Maryland growing burden of chronic disease and mental disorder, substance abuse, and rising healthcare costs. How will the state structuring the preventive care, primary care? So what is the policy on that? So we heard a lot about intervention, but I didn't hear more about preventive care. We can increase, the quality care for the patient, and then you can save a lot of thousands of dollars. So what is the policy going on right now?
So the question is kind of how do you get upstream in prevention? Yes, it's a great topic. Thank you.
That's a great question. Thank you for asking that. I will say a few things. Number one, with the new AHEAD model that we were talking about, there is a primary care investment target as part of that, by which healthcare dollars must go towards primary care. So that's one way. Another way is, we mentioned the VAX Act in reference to vaccines, which of course is one of the best tools that we have for prevention of infectious disease. The VAX Act also includes preventive care and screenings. So the Secretary of Health has the authority to make recommendations on preventive care and screenings that have to be covered then at no cost, at no out-of-pocket cost by regulated insurance plans. So that's a second way that we're looking to strengthen around prevention. And the third way, I mentioned it, I think this is an opportunity to drill down a little bit more, is that the Maryland payment model has something called the Population Health Improvement Fund, Population Health Investment Fund, whereby we're able to take dollars that are in our healthcare system and invest them in population health efforts that we know, to your point, can keep people healthy and then keep them out of the hospital. So one of the first uses of that Population Health Investment Fund that we're doing is medically tailored meals. So we've launched this across 6 counties in Maryland, from the Eastern Shore to Western Maryland and urban areas, where people with diabetes who get admitted to the hospital or come to the ER, if they screen positive for food insecurity, the hunger, then they can get 6 months of medically tailored meals for them at no cost to them. There have been studies that show that doing so leads to improvement in the care for their diabetes and prevents readmissions and ER visits, which ultimately will save money. And so we're rolling that out across the state, and we plan to further evaluate how that is impacting downstream hospital costs.
Great, we have a question here. Thank you.
Hello, Secretary. Thank you so much. I'm Jean from HC International. Question, we spoke about workforce and e-development. We think about what we need to read. We also know that there are a number of professional opportunities that are needed to really address disparities. So we could talk about community health workers, doulas, peer recovery specialists. When we think about the population that we need to get that 80 hours of work, which of the any particular categories that you would say your administration is focused on that we can help some of these individuals get job trainings, get ample opportunities so that they can go back into their communities and we can really address on multiple levels. So you had workforce, you had, sustainable professional opportunities, you had disparities, you could hit a number of boxes in looking at those particular professional areas. So any particular areas, especially too, with the rural health transportation dollars.
You're exactly right. I mean, the benefits of investing in our workforce is both for the workforce, so that you're able to have people, working in healthcare to improve access, And it's also for those people who need to work to be able to stay on Medicaid. I think there is that dual benefit. I say D, all of the above. I mean, we are looking, so as I mentioned, we have some, more shovel-ready programs that are already in existence, as I mentioned, around care recovery. We are also looking to expand those to include other areas like community health workers. And I think importantly, how it dovetails with rural health is important because we know that in rural areas, you have a much higher prevalence of Medicaid. And I know particularly for rural providers, there's a lot of concern that if people lose their healthcare coverage, how are they going to keep their doors open? Maryland, because of our unique payment model, has always performed the best in the country in terms of keeping the doors open for rural hospitals and rural providers. And the changes that are coming to Medicaid definitely can create a strain on that. And this is a good example of how we can work smarter to try to have that win-win. So thank you for that compliment.
You talk about how Maryland is a leader in, you talk about CRISPR, you're talking about, or CRISP, excuse me, you're talking about the all-payer model, sorry, confusing the models. What has surprised you about healthcare in Maryland? Because you obviously worked in healthcare in Maryland in the area as a physician, but you see different parts of it now from your perch. So what has surprised you, and thinking about a broad swath that's stakeholders across Maryland, do you have a message for Maryland healthcare leaders about where you think we are and where we need to go?
So I'll start from, you're exactly right. When I talk with other states or when I talk with people around the country, so many people say, we want to be like Maryland. How can we become like Maryland? So yes, it's very proud to be in Maryland. I think what has surprised me is perhaps a little bit more personal. So, I grew up in New Jersey. They say you could take the girl out of Jersey, but you can't take Jersey out of the girl. But I've actually lived in Maryland longer than I've lived in the state. And I've raised my kids in Maryland. This weekend, my son has a volleyball tournament where he will be representing Maryland, and I have Maryland pom-poms to thoroughly embarrass him. But what has been surprising is just the diversity of our state, and our state really is like a microcosm of America, right? You have like Western Appalachia, you have urban areas, suburban areas, you have Southern Maryland, farmlands, you have the Eastern Shore, Ocean City. We have it all in our state, and it's just been so, I don't even know what the term is, wonderful. Just to feel like I can connect with so many communities who all really feel this sense of pride in being a Marylander. I mean, I don't know what my New Jersey state flag was, but look, I got my Maryland flag. My kids know all about Old Bay and craps, and I feel like there really is like an esprit de corps in Maryland that is really special. And whatever the ahead policy model, all-payer alignment is, the reason all of that can be successful, I think, is because of that sense of community that Marylanders have that I don't necessarily think is everywhere. I do think that is like a special sauce for Maryland, maybe with some Old Bay.
What a great note to end on. Unless we have one more question. Did you have one more? I cannot see. No. Okay, we're good. Well, let's leave it there. What a great note to end on, thinking about the distinctives of our state and the leaders in our state. And I want to thank this particular leader of our state. So will you join me in thanking Dr. Seshamani?